Hello and welcome to the Imaging Wire Show. My name is Brian Casey, managing editor of the Imaging Wire. Got another great episode for you today. Our topic is imaging's multimodal AI future. And our guests are Cameron Andrews, founder and CEO of Sirona Medical, and John Bertrand, co-founder and CEO of Digital Diagnostics. Cameron and John, thanks for being with us today.
Thanks, Brian.
Yeah, thanks for having us, Brian.
So can you tell us a little bit about yourselves and your companies? Cameron, can you go first?
Yeah, so I'm the founder and CEO of Sirona Medical. We have re-architected all of the software that radiologists need to practice. So viewer, PACS, reporter, work list, et cetera, on one unified and cloud-native platform. This has some pretty profound sort of performance and value characteristic differences from how radiology IT has been architected before. And one of those we're going to talk about today, which is the ability for AI to impact the radiology process and product in a way that just previously has not been possible.
Awesome. Well, we're looking forward to it. John, how about you and Digital Diagnostics?
So John Bertrand, I've been in healthcare since 2006. I spent my first 13 years at a small company. I first joined it called Epic, but became the largest EMR vendor in the world. Spent a little bit of time in VC where I originally met Cameron, and I was really working on a lot of different applications of AI in healthcare. Digital Diagnostics was one of those that we invested in. And about 5 years ago, I joined the team full-time as the CEO, and we're known for creating the first ever fully autonomous diagnostic algorithm, meaning we diagnose the patient without the physician in the loop. Our first use case is in ophthalmology, the diabetic eye exam, and we're in about 500 clinics, scaling to about 1,000 by the end of the year. So really kind of past that 0 to 1 point where AI is becoming mainstream.
Great. And when did you start selling the product?
We started actively marketing it with reimbursement, which would be about 2021, I want to say. It's either 2020 or 2021. It's hard to keep it straight after this many years working on the problem.
So pretty recent then.
Yeah, relatively recent in the grand scheme of healthcare.
Great. So this is a radiology audience that watches the Imaging Wire show, and their primary interest is radiology AI. But I think that a lot of people see real potential for AI in healthcare as being more of a multimodal technology that can apply to radiology and ophthalmology and cardiology. And John, can you go into a little bit of a deeper dive into digital diagnostics and talk about exactly what you're doing in AI and the kind of the challenge that it addresses and the use case for it?
Sure. So there'll be lots of parallels with what happens in radiology here and where the applications are similar between the different specialties. So we take a digitized fundoscopy image or fundus image, which is captured through a camera that's been around or I should say, a medical imaging device that's been around for over 100 years, which is digitized in like the last 10 to 15. And the current situation today, or I should say, patient pathway, is they would be referred from a primary care to a specialist to receive the test. They'd go to the office, they'd have the test done. What's been introduced in the interim is teleophthalmology. So think teleradiology. Image is captured remotely, beamed to a physician sitting someplace, grading the image, essentially producing a diagnostic that comes back asynchronously. We're taking it a step further, where we are replacing the physician's work effort with the GPU, essentially, to do this. And it's for a narrowly defined task, diabetic retinopathy, or the diabetic eye exam, as it's known more commonly. So similar to teleophthalmology or teleradiology, images captured remotely, sent over, but instead of going to a human being, it goes to a computer that processes it in sub 10 seconds and produces a diagnostic report back with an ICD-10 code. And we actually have a CPT code for the computer's work that can be billed by the site that captured the image originally. So again, lots of similarities to radiology. We've just taken it a step further in this narrow use case. Obviously, the diagnostics you try to drive off medical imaging are 10x, if not 20x bigger in radiology. But again, a lot of analogs between both specialties and the opportunity that AI presents.
Cameron, where do you see some of the parallels between what digital diagnostics is doing in ophthalmology and what you guys are doing in radiology, and maybe the similar areas of the specialties where things are the same?
Well, I think it's one of the really funny things that John and I have talked about for a long time, going back 5 years to whiteboarding out some initial theses and strategies that really became Sirona in our earliest days as a company, which is that at the same time as I would think John and I both believe radiology will not be automated predominantly or in any material way by AI, The same thesis then drives the more autonomous part of digital diagnostics strategy and the product that they brought to market. And so there's this very funny sort of moment that John and I had 5 years ago, where when we were whiteboarding out what our company was doing and what digital diagnostics was in the process of bringing to market, the same underlying thesis for the evolution of imaging's AI future can lead to very different outcomes in the strategy that AI should bring to ophthalmology as a problem and to radiology. I think one of the key sort of examples of the difference between the two is in radiology, the diagnostic problem set is fundamentally more complex, and there really isn't a clear ground truth in a lot of the diagnostic problems that radiologists are working through. So if you built an autonomous AI that, as an example, diagnosed or qualified, lung nodules on their own as a problem, the physician, the radiologist, is still responsible for interpreting and analyzing all of those other pixels and voxels in that image. And far more than that, they're responsible for interpreting and understanding the progression of disease across many prior exams, and the sum total of that problem and the report that results from it is the radiologist's work product. They're not answering one sort of single and fundamental question. Predominantly, the overwhelming percentage of imaging that's done today is more diagnostic in nature. And so the result of that is a problem that, from an AI perspective, leads itself to a far more assistive strategy, even though the underlying thesis, I think, for digital diagnostics and for Sirona is very similar, which is the future of medicine generally is going to be powered by AI-powered specialty-specific workflows that make physicians more efficient on an hour-for-hour basis, because they're going to have to be, and more effective in a way that results in higher quality and lower cost patient care downstream. Because if you can do that, and you can do both of those, then you can potentially get reimbursement, which digital diagnostics has done, and which we're starting to see on the radiology side of the equation. So that's a fundamental difference, I think, between the two. Same strategy resulting in assistive versus autonomous AI in ophthalmology versus in radiology. The second sort of, let's say, in the compare and contrast, the comparison between the two is sort of self-evident, which is there are problems within the scope of the radiology problem itself, where this kind of assistive but far more predictive AI capability, this radiomics as a category, can fundamentally improve the quality of downstream care. One example of that is something that we've helped bring to market with our partner Reveal DX, which we did a wonderful interview with you guys before, and people should check out on the Imaging Wire's YouTube channel, where their CEO Chris Wood and I sat down and talked about this. When you're predicting whether or not a lung nodule is likely to be malignant or benign, the sort of clinical toolkit that physicians have to make that determination today can be made better by AI, and as a result, can reduce the downstream costs and improve the downstream quality of the care profile. That is a kind of algorithm, a kind of capability that starts to look a lot more like a bridge to what digital diagnostics has done in ophthalmology and is doing on the autonomous side of things without actually taking the physician out of the loop. And so I think if we were going to draw a spectrum of AI from assistive to autonomous, digital diagnostics represents sort of the ultimate representation of the autonomous side of the equation and is improving quality in ophthalmology as a result of that. Sirona is very much on the assistive side, but our platform is built to allow for this class of algorithms in the middle, these radiomics algorithms, to be able to get distribution and to have that impact on the quality of care that they're capable of doing.
Gotcha. John, can you dive into a little bit more into this idea of autonomous AI and ophthalmology? Because it's something that in radiology we've just sort of starting to scratch the surface, and there's a couple of companies out there that are trying to do something like that. But it sounds like you guys have kind of really dived into that.
Yeah, well, we were the first to get FDA approval for an autonomous algorithm. We're still the only to go through de novo and do it. So right now we're the only real use case of it, and the pioneer, I'd say, in the space. But the idea here is you are literally removing the clinician from the workflow. There's no overread. There's no second check. It's data in, diagnostic report out, CPT, ICD-10 flow from that, as I mentioned earlier. There's a few things that are unique in our use case as compared to the broader radiology opportunity that's out there. And one is there's a very well understood ground truth for diabetic retinopathy and several other eye diseases. And that's a bit different than what we see when we look at radiology. What I mean by that is if someone has diabetic retinopathy or not, there's literally a grading scale where a certain amount of particular biomarkers that are present calculate out to this is a score on a scale. Each of these scores correlates to a category of no disease present, more than mild, severe disease present. So it's one of those, first and foremost, like well understood from a science perspective. This is what the disease looks like, would be number one. And then number two would be, I think that's a little bit different, is an ophthalmologist from a day-to-day practice perspective isn't just reading fundoscopy images and providing diagnostic reports. They're doing interventions, treatments, patient educations. They're looking at disease states that don't have a ground truth yet, trying to suss out what's actually going on with the patient. So what we're actually doing that's quite a bit different from a workflow perspective is I'm saying, let me take off of your plate all these highly repetitive, very narrowly defined tasks that are not top of license. So that way you can shift your focus to all the patients that are currently not getting this annual test done. And essentially the physician is allowed to shift their focus to these more challenging interventions, to the patient education, to making sure they're continually coming in to maintain this treatment that ultimately saves their vision. So there's a few nuances that are different, but that's just a quick summary of kind of like what we're doing, what's a bit different about our particular set of use cases. I still think there's a place for our assistive AI where we can't otherwise understand what the ground truth is going to be, or where we're essentially prioritizing things for clinicians, helping with documentation. Like, again, there's still many positive use cases, especially in radiology for assistive AI. There's just this unique set of criteria where I believe it needs to be autonomous, and we need to offload and unburden the physician from things that are well, clinicians and researchers for years have well understood. This is disease, this is the intervention, and we know it drives an outcome.
How receptive have clinicians been to this idea of autonomous AI? I know in radiology, initially there was a lot of folks were
not initially, still very much so, as there should be.
Yeah.
In radiology.
In radiology, yeah. But in ophthalmology, are they, how do they feel about it?
It's evolved over the years. So when I first met our founder, Dr. Michael Abramoff, he let me know that he had the name of the retinator, the nickname in the industry, because he came out and said he was going to use AI to diagnose patients, and everyone said he's coming for our retinas. It's gonna impact our livelihood. And over the years, as we've gotten our message out there, look, this is about getting you to top a license. This is not about taking work away from you. As a clinician in the United States, do you have less work than you want or more work than you want? Well, the answer is more, and we all know that. And there's a variety of large demographic trends that make that so, and will continue to make that so. So again, it's really about helping people understand. I'm picking a particular use case because we understand the disease. We know what the disease looks like. I can benchmark it. I can monitor this algorithm. There's transparency. It's a big part of how our whole universe is set up, or we can go back and pull, why did the AI do what it did, and be able to explain that to an eye care professional. So over time, it's turned into something where we're often brought in and welcomed by the specialist into their ecosystem. So there's a large academic where the show go nameless because I didn't ask their permission podcast, but the call to be brought into this large academic university with a national brand came from the head of ophthalmology. We're getting killed on the volume of diabetic retinopathy reads we have to do. My physicians are not getting to the actual treatment. I have a capacity issue. There's patients in outlying areas that don't have access to this test. Somebody in a rural or urban area might not be able to get to the specialist at the AMC in the center with the highly credentialed specialist to get the test done, but they would certainly go if they knew they were going to go blind if they didn't. So a lot of that is, again, just helping people understand what we're doing. I'm not saying I'm taking care of the entire eye exam for the year. There's too much human cognition involved in that to be able to replace it at this point in time. What I am doing is kind of cutting off those things that are essentially burdens to the system.
And I think there's really good examples for the difference between, I think, what the two approaches are for the two companies. In radiology, we believe the predominant efficiency value of AI is going to come from a breadth-first approach, whereas very much what John's describing is this depth-first approach, finding a kind of work you can completely unburden from the physician. That depth-first approach, they're wonderful examples of how this has improved the quality of life, as well as the quality of medicine, as well as the profitability of certain specialties over time. Like if you look at the autonomous interpretation of EKGs and the work that started, the sort of proliferation of that, some 30 plus years ago at this point, you had cardiologists saying, what is this going to do to our profession? And the reality is it allowed them to focus, as John was talking about, on more top of license type tasks, as opposed to that screening type work. And so the result was, by finding a kind of work that computers could offload from physicians, you allowed physicians to do more of the kind of work that they wanted to be doing in the first place. Yeah. In radiology, there are some opportunities for that, but overwhelmingly, the opportunity today from an efficiency perspective on the AI side comes from a breadth of tasks that happen on every case, whether it's a chest CT or a chest X-ray or a spine MRI, that physicians have to manage that they just shouldn't. And this is really principally why we started Sirona, and in so doing, sort of started rebuilding radiology IT from scratch. Because we believe you got to do two things concomitantly in order for radiology to have the brightest possible future. Number one, you got to give physicians hours back in the day. Like, no radiologist on earth today thinks that they have enough time to be able to do the job they want to do and live the life that they want to live. And that is a worse future for medicine if we can't solve that problem. And then the second point is to say there is this incredibly exciting new kind of information that's starting to proliferate and make its way into medicine, whether that's genomic information or other multi-omics data, or generally AI systems that have so consistently in the clinical literature demonstrated the ability to amplify certain care pathways and quality of care to patients by looking at different kinds of discrete data all in one unified analysis. You have, for the first time really since the proliferation of advanced imaging, a new kind of data and analysis that radiologists, but generally we'd say medicine, are starting to incorporate into that diagnostic toolkit. We saw this with the advent of MR back in the sort of MR and CT back in the day. People would say MRIs are so clear that like orthopedic surgeons are just going to read these images and we don't need radiologists. And of course, it was in that moment that we radiologists did what so clearly was the right thing for patient care, which is say when there is a new form of data or a new form of analysis, it demands that a specialist subspecialize on the interpretation of that data in a way that results in better patient care. And so our belief is that another one of those moments is really a handful of years away. It's happening now. And CMS is starting to create the reimbursement pathways around radiomics and other things that really are, we believe, are going to allow for a real sort of boom in that space. And radiologists need a new data to analyze like they need a bullet. Like they don't have the time in the day to focus on what comes next for the radiology product because they're drowning in the data they have to analyze now. That's where AI can solve things like hanging your cases the right way. It's a small thing. It makes a huge difference. So building an AI-powered hanging protocols engine is the easiest AI solution ever built, and yet it's an impactful one for the physicians who read on our platform. Data normalization, the ability to use voice commands to drive actions across the entire application. These are not things radiologists would say threaten my job. No one would say AI can hang cases the way I want. That threatens my ability to own this specialty moving forward. It's the efficiency that drives that will allow, we believe, physicians to have the time and the space to reimagine their work product moving forward and to see, thanks to that breadth value AI, more of the depth kind of AI that digital diagnostics is pioneering and represents, that we believe becomes then how radiology reinvents their product, as well as the process whereby they do their work.
Now, Cameron, you mentioned reimbursement. John, Digital Diagnostics, you guys have secured reimbursement for your AI, correct? How did you go about doing that?
Well, we worked with a variety of stakeholders around the table. So the AAO, our Society for Ophthalmology, was a huge proponent of this. We worked with the AMA, had conversations with those two groups years before we even cleared the FDA, kind of working towards the eventual clearance. So, by the time we cleared, we had all these different societal people aligned. AMA, AAO, American Diabetes Association is another great example. This is the disease we detect impacts their constituency. So we really went more of the coalition approach to CMS and sat down and said, look, we have an FDA cleared product. We are in use. Here are our invoices. Here's our outcome related data, and really focused on the quality we're able to convey to the patient. Ultimately, the CMS's greatest stakeholder there, the taxpayer and the patient. So that's how we kind of thought about it from a strategy perspective. There's a lot of other nuance in there that's competitive advantage, understanding how to get the government to look at AI differently than they do everything else, because there's these RVU units, as your listeners I'm sure are well aware, underpinning how a reimbursement is calculated everywhere else in the industry. And it's the first time someone said, well, now there's not going to be a doctor involved, but we still provide value. And it was one of those, I think the best analogy I heard was from our COO, was like, we rolled up at the DMV with a hovercraft and they're looking for a motorcycle car truck. And you're like, yeah, but it still gets you from A to B. And they're like, yeah, but there's no box for it. What do I check? So we were really lucky to have folks at CMS really sit down and try to partner with us and find a pathway. But again, it goes back to, from the beginning of the design of your product, working with your various stakeholders to make sure we're on the right path here in our logic of calculating how does this provide value to the patient.
Yeah.
So a few other things I might touch on. It's reimbursable in primary care. So you can provide a specialty test in primary care, retail health, laboratory draw stations, and still receive reimbursement, even though it's an eye care related test, which was very challenging to get that all figured out and mapped, because if you're going to automate a test, you're shifting the site of care and you have to think through your place of service as well. But I think it's really unique in that the way that the reimbursement has shaken out, we are adding more value and are reimbursed higher than teleophthalmology. We're not the same as going to have an ad in the chair exam with the specialist, though, because we're not checking for everything else other than our one defined use case. But at the same time, all these patients are getting these tests done today, and everybody's dealing with a supply and demand issue where patients are demanding more tests than their supply of. So it kind of works out for everybody involved in this, where we're returning value back to the system from a financial perspective, while also providing our end users, provider organizations in primary care, more upside than using the alternative inferior outcome-based product.
Yeah. Cameron, do you see that as a model for radiology AI?
I think there are three things that, from what John just said, that radiologists should take away. The first of which John and I have laughed about for years, in part, which is the whole false dialogue about like radiologists and physicians losing their jobs. Like even Digital Diagnostics and John and the company that has pioneered autonomous AI, nobody believes radiology is being automated. Nobody. Now, mammography, there are some examples where highly sensitive AI can help to reduce the overall workload there. But that's a totally separate point, and it's kind of a niche and specific application. So that's really the first and most important point here. The second one, I think, is also the most important, is sort of the second most important point, but is critical. And John, you might characterize this differently. But when Digital Diagnostics talks about the value of what they bring and why reimbursement deserves to be what it is for the platform that they've brought to bear, the autonomous component of it is the delivery vector for a quality improvement. And so what we're talking about is improving the quality of downstream care and making the financial argument to the government and to payers generally that that is worth paying for. That is something that's not specific to ophthalmology. It exists across all of medicine, obviously, and it's how we push medicine forward. And so I think the fundamental thing that radiologists need to internalize and sort of see moving forward, if there was one thing that people could take away from what I'm going to say today, I hope it would be this: nobody is going to pay for efficiency AI. And therefore, the efficiency driving AI is going to have to be a part of your underlying IT solution. It's the only way these practices who are fighting declining reimbursements on the professional side and increased work volume and physicians being as overburdened as they are, it's the only way we're going to be able to get the value that AI can bring to the efficiency problem for radiologists within the budget that these practices have. And that is a critically important point. And then there's the quality AI. And there's been some argument over time that like detecting disease in radiology or one kind of condition or another can help to improve quality. And it very well may in certain conditions. But there's this entirely different kind of use case that we believe is going to be the overwhelming majority of the computer vision value that's delivered to radiologists on a 5-year basis. And it looks so different from the kinds of AI that have been shipped up until this point. And it comes down to not detecting a disease on its own or quantifying that disease on its own, but really characterizing that disease. And I think with businesses, the reimbursement pathway that CMS has started to make clear, and some of the breakthroughs that we've had in reimbursement around some of these products, like Akios or Reveal DX, Perspectum, so on and so forth, you have the beginnings of a program that we think is going to become even more important over time, which are the kinds of AI that don't look like how are you automating away a task for a physician, but once disease has been identified, how are you appropriately characterizing that disease in a way that can help improve the quality of patient care downstream. That today involves just the analysis of image data. And it's clear that there is subperceptual information that can be used pixel to pixel level correlation and data, information in that data that can be used to improve the quality of that interpretation process, that characterization process. But where it starts to get really interesting and non-linearly valuable to downstream healthcare is when you start to incorporate in different kinds of information into that analysis, that multimodal AI future for diagnostic healthcare, with radiology characteristically being on the cutting edge of that. And that's where we believe a platform change, a brand new technological foundation that will allow not just for radiologists to be able to interpret today's data more efficiently, but tomorrow's data effectively is what's necessary for radiology's brightest future. that's what we've been building for the last 5 years and what we're going to be launching on the 13th, but I think we'll touch on that later.
Yeah, we will. So Cameron, do you see at some point in the future, 10, 15, 20 years, do you see clinicians just using a single AI platform for all of these different specialties, ophthalmology, radiology, cardiology?
I think that a world where one single platform controls all of those specialties is something that is intellectually interesting to talk about, but it kind of misses the point of modern SaaS. When you build technology, software in a modern and a cloud native way, as John and Digital Diagnostics have done for ophthalmology, as Sirona has done for radiology, whether or not these are all separate businesses or not, that's not what physicians care about. They care about the coordination of data in a way that feels as if it's one product. You don't have to have one company to deliver all that value if you have a modern technology stack. I think the reason why people are interested in that conversation and where we get into enterprise imaging today as a general category is because when you got old school technology, you have to try to stitch it together yourself or it's just never going to come together. However, the ability to bring pathology data and ophthalmology data and cardiology data and radiology data together, when you build modern software, cloud native software, whether those platforms are separate or whether those platforms are the same, the experience to the end physician can be exactly the same. It can feel as coordinated as it would if they were one business or not. And so actually, we think what's best for the future of medicine is that these are not one company. We believe that the best thing for the future of diagnostic healthcare is that cardiologists get the best platform for cardiologists, and radiologists get the best platform for radiologists, and ophthalmologists get the best platform for ophthalmologists, and so on. But that all of these data become accessible and these platforms become integrated in a very sort of horizontal way that starts to look like the fact that, if you got Slack or Microsoft Teams today, you can plug those products into every other product on earth. And nobody is saying, well, why doesn't Slack control everything that it plugs into? It's just one thing does one thing and all the other things do what they do, and you stitch them together in this way. And that's really what the beauty of modern software as a service, cloud native software has been for the last 10 years in the broader technology world. And so what we believe is that by building a vertically integrated, radiology specific workflow platform that helps to make radiologists more efficient and more effective over time, that we have created one component of what we believe is going to be a broader revolution for diagnostic imaging. Because as this happens for every other part of the imaging puzzle, you start to be able to do some really cool things in partnership with one another. And that's what we believe the future is going to look like.
Excellent. John, any thoughts on that, this idea of a unified platform?
It sounds so similar to what I went through during the meaningful use era that drove the adoption of EMRs, that it's almost hilarious. And that's honestly 5 years ago where Cameron and my first dialogue started on, hey, how do you end up providing providers with this AI future that we both saw coming? And it's like, well, we need a unified workspace for everybody to be driving their workflow off of that has contemplated in advance kind of where the technology is going. So like, I've seen this before. I've somewhere between Brian, your level of experience in this industry and Cameron's at this point, and I've seen this play itself out before. So I very much believe that that's where we're headed. I think technology is at a point right now, especially around medical imaging, where it's, again, I agree. I don't think we need one monolithic vendor trying to serve everybody here. But again, this concept of the physician operates off of one single workflow workspace, and these other technologies are contemplated coming in to assist and aid them here looking forward, I think is the right next move. And as you look at the market, especially on the radiology side, what's out there today are all these, they tend to be predominantly these on-prem solutions that have not contemplated the fact that things are going to be going to the cloud. You're going to have a lot of third-party content you want to integrate in. You want some configurability and customizability without calling back to your large monolithic box vendor asking them to make a change that comes with a change order that has a price tag. So I think Cameron's spot on where this is going. I think if you've been around the EMR digitization of the clinical record, you've seen this before. Heck, if you were around the original PACS, moved from film to PACS viewers, you've probably seen this play itself out. It's a natural life cycle of these technologies, right?
Yep.
You make a big leap forward, everyone adopts them, gets as much value as they can, and then we start to realize where we need to go next. And we're roughly at that point right now in the radiology space.
Yeah, as a funny tangent and story, my grandfather's a radiologist, and I grew up around private practice radiology. And one of the stories that he told me about the early days of MR was how important incorporating a homunculus into their intake process was, because he was a spine radiologist, a spine subspecialist. And so knowing where the pain was localized had a profound impact on the sensitivity and specificity of radiologists as they were working through that diagnostic task. Now, I don't think today people would look at a homunculus on your intake form and say, therein lies the evidence for radiology's multimodal future. However, that is multimodal data. You're taking in information from the patient about where the pain is. You're including image data in that analysis, and humans are more sensitive and specific. AI is very good at very different things than people are good at. However, that example alone demonstrates the following point. What AI can do to make radiology better, both from a quality perspective, but honestly better from a quality of life perspective for physicians, comes down to the kind of information we can feed into it. And so to that end, what radiologists need is not AI that's going to do one thing or another thing. They need AI to improve every part of the process as a whole. And to that end, it's clear that this technology can do that. And the last 5 years have really been an illustration in the fact that it really can't with today's underlying IT stack, as John was describing. And so I think one of the things that Digital Diagnostics and Sirona have long shared from a strategy perspective is if you want to improve it's sort of diagnostic imaging generally, you have to start from a first principles perspective and rebuild the technology stack to deliver whatever AI-powered value you want to deliver holistically. For digital diagnostics, that started with diabetic retinopathy and improving the accessibility and the quality of that screening process across healthcare. For Sirona, it was about making radiologists' lives better and the quality and the efficiency of their process better as well. And so that required that we re-architect the whole platform foundation underneath radiology, rebuilding radiology IT as a modern cloud-native platform, so that not just can we deliver that value, but we can help third parties deliver entirely new kinds of AI value over time. Yeah. And that's what we're just starting to scratch the surface of showing is possible and delivering to our customers and to our physician partners today.
Well, I think that's a great lead into your upcoming product launch. Can you talk about that a little bit and what you can tell us ahead of time?
Yeah, I don't want to steal our thunder from what has been a great many hours and weeks of being on camera and getting our customers and our partners and the AI vendors with whom we've partnered as well on camera to tell the story in turn. Very simply, what we're launching are a series of products that we've been working on for a long time. But what we're really launching is the first handful of software that's built on top of the first new technology stack introduced into radiology IT in over a decade. And so for anybody who's interested in what we're doing, please check out our website, sironamedical.com, and see the content that we put together to illustrate what we're launching. But really, what this is a 5-year process has been a 5-year process of building a whole new technological foundation for the industry on top of a brand new technology stack, which is really the first time since radiology digitized that's happened. And what we're able to ship on top of that is value that for the private radiology practices with whom we've partnered to date has allowed for asymmetric value creation for those practices, dramatic operational efficiency improvements, clinical efficiency improvements. We published a case study last Monday for one of our customers who's experienced a 20-25% clinical efficiency improvement just from the core platform alone. And that's before all of the AI-powered features that we've layered on top. So I don't want to steal our thunder from the launch, but anybody who is interested in sort of getting a modern technological foundation through which today efficiency driving AI can be delivered at no additional cost because it's just part of the core platform, but also through which radiology's multimodal future can be delivered over the next 5 years, which we believe is necessary for radiology's brightest future to occur. That's the platform technology that we'll be launching.
Great. Can't wait to see it. And I guess people will probably also be able to see it at RSNA coming up.
They absolutely will be. And there will be a tremendous amount of AI-powered value that will allow folks to play around with behind the scenes should they be interested, that goes above and beyond what we're going to be launching on the 13th as well. So we'll have even more cool stuff to show people behind closed doors for those practices who are interested in getting their hands on our technology and buying our platform today.
All right, very good. All right, well, I'd like to thank you both, Cameron Andrews of Sirona Medical, John Bertrand of Digital Diagnostics, for being with us today. Gentlemen, thanks again for your time.
Thanks very much, Brian.
Thanks for having us, Brian.
All right. Signing off for the Imaging Wire, my name is Brian Casey.